Good morning. Can anybody hear me?
Yes.
I'll do, okay, so it's 9 o'clock. I'll do a quick check round. My name's Mike. I'm chairing this session. And I'll just do a quick check round of all the screens I can see to make sure you can hear me and I can hear you. So Catherine Riley.
Hello.
Hi. Fiona.
Hi there.
Kim.
Hi, how are you?
Excellent. Good. Thank you. LJ.
Yes, thanks.
And Avinash.
Yeah, hi.
Brilliant. And is there anybody, I can't see anybody else on my screens, but is there anybody else out there that can hear me who? So we probably will get a couple of other people join us during the call because there's more than the five. Thank you very much for submitting your presentations. This should be all straightforward and painless, I hope. What we've been doing for the last couple of days, going through all the abstracts, is, or what I've been doing, and there's a couple of us doing this, Monty Mython's also running some sessions in parallel. What I've been doing is asking you to give maybe a 1 or 2 minute quick summary of your abstract, and then having questions for about a further 4 or 5 minutes. So total of 6 minutes per presentation. And I will ask a couple of questions, and sorry, the perils of Zoom at home. I will ask a couple of questions, and then you're very welcome to ask questions of each other. And the only request, and I'm sure you'd have done this anyway, but if they can be constructive rather than critical. Now, the presentations we've put into a PowerPoint format, so I can't tell you what order you're coming in. So there's a little jeopardy in the whole thing. A slide will come up, but what I will do is give you a couple of seconds just to sort of compose yourself and get your thoughts together. And it means you can't be nervous about being next because you don't know, it might not be you for a while. So if I start by sharing the screen, if that works, which it has done previously, and then just a few introductory comments, and then we'll roll into the first of the presentations. So, can you see just a single slide of EBPOM abstract poster forum?
Yeah.
Yep.
I'll remove the pictures of you guys, apologies. So we've got roughly an hour. We may need to overrun slightly, but hopefully not. So as I said, thank you for coming along. Thank you for submitting your abstracts. Well done for getting through to this stage. There are 6 poster finalists who will be presenting live to the whole audience, and we've now got nearly 8,000 people signed up for the meeting. So I don't know how many will be online at that point, but if you're a poster finalist, you do know about it because we've been in touch. So well done for getting this far. If any of you are in the final as well, congratulations. But if not, I encourage you to dial in if you can. Those are on Wednesday and Thursday on the main EBPOM stage. And hopefully you have a feel for the EBPOM program. So we've got pre-recorded lectures going live from tomorrow morning. And then the truly live presentations, which are all panel discussions, will be from Tuesday morning at 9 o'clock, and they'll be on Tuesday, Wednesday and Thursday, as we normally do with the face-to-face EBPOM meeting. And then over 24 hours, over Thursday night into Friday, we're kind of going around the world on a Pomapalooza to the East Coast and West Coast of the States, across to Australia, and then up to Hong Kong. So there'll be a 24-hour kind of broadcast sequence. We're mostly academic, but there's a few musical interludes and a few other bits and pieces. So if you can visit some or all of that, then you're very welcome. And our ambition over the coming year, in the face of the whole COVID-19 challenge and the fact that we can't really meet face-to-face, is to run all our meetings, and we have several internationally, but particularly Chicago and Las Vegas in the US, and Dingle, which we run in October on the west coast of Ireland. So to run all these meetings virtually, which means you can put abstracts in from wherever you want, you can access them wherever you want, and we will be putting that content together if you manage to pick up all of that into a post-operative perioperative care certificate via our e-learning platform at the end of it. So that's probably enough from me. Really looking forward to your presentations. I'm just going to get my phone ready for the timer. So there's a little bleeper that will go off when the 6 minutes is up. I'm not going to cut you off if you're mid-sentence, but we'll use that as a signal to move on to the next presentation. So first up is Dr. Hogan. Are you on the call? If not, we can come back to it.
No, I'm here.
Excellent.
Can you hear me?
Hi. Yeah, I can hear you. So,
Hello. Hi.
let me know when you're ready
Good
to go.
morning from Adam Brooks over in Cambridge, everybody, and thank you for the opportunity to present. Yep, I'm ready to go.
Fantastic. Off you go. Thank you.
So I'm going to present. You want me to start? Sorry.
Yes, please. Thank you.
Okay, so I'm going to present somebody's got to go first, right? I'm going to present data from an audit that we did, which was set up to answer a quite important question. And this was in collaboration with colleagues across the hospital, but notably also pharmacy, and I'll explain why that's important during the talk. So why record patient weight? Well, it helps with risk stratification, of course. Obesity and the identification of it can determine whether the patient is suitable for day surgery or will need specific equipment in theatre, etc. In terms of drug dosing, it's incredibly important, and not just for the cheaper drugs like the paracetamols where pennies can be saved, but also more expensive drugs like IVIG, which may be used extraordinarily, for which it's quite expensive if you open the equivalent of 2 vials rather than 1, but also for ventilation strategies. So I'm thinking here with ARDS, but also, of course, with the issues that have risen with COVID. So that's ventilating on a tidal volume, which is calculated by kilogram. So weight is normally measured, and most people assume that it is measured, but in a lot of cases it's estimated. And in Adam Brooks here, we use the electronic note system called EPIC, where we're able to tell if the weight has been estimated and the date that it was done quite easily at the banner at the top of our files. And we're able to see if it was actually measured when it was done or if it was estimated. So in terms of our surgical patients, we measure weight at the preoperative assessment clinic. We no longer measure all patients routinely on the day of surgery. We got clinical audit office approval for EPIC chart review, but also to reweigh a proportion of patients on the day of surgery. So first of all, I just want to answer the common assumption about the 70 kilogram adult, which is now of course incorrect. The mean weight is 80 kilograms, higher for men than women, as you'll see in the middle figure. And then looking at the estimation, so this comes from a subgroup of our entire group of 278. So looking at a subgroup who did agree to estimate to be made, then there's estimation. And this showed, if you look at the weight underestimated column, that the greater percentage tended to underestimate that patient's actual weight. And that's unusual because in most publications that have gone previously, people overestimated weight. So I don't know what's happened there, but patients were that the patients were more between the patient and healthcare professional weight estimates. So in terms of the other thing that we were interested in was the difference between the preoperative assessment weight. It could be anything from just a sort of a couple of days, or in some cases where surgery had been delayed. First of all, there was no association between weight change and the interim between preoperative assessment and day of surgery weight. And the degree of change in terms of means or median, between the preoperative assessment and the day of surgery was only about 0.8 kilograms. So we're talking small fry. However, that ranged from approximately a loss of about 4.4 kilos to a gain of about 9 kilograms. So there could be, quite some variability within that. Most patients, so 2/3 of our patients, actually lost weight between preoperative assessment and day of surgery. Approximately a third gained weight, and then a very small minority maintained their weight. So what we have is that the average adult now weighs approximately 80 kilograms. If we are guessing weight, because for whatever reason, whether it's an emergency or whatever, then the patients, if you ask the patients themselves, they're usually better estimators. The patients guess best. Most of our patients actually tend to lose weight in the duration between preoperative assessment and day of surgery. So we now recommend using day of surgery weights. The reason that is important is because our pharmacist has gone through a number of drugs and identified that even if you are 1 kilo or half a kilo between weights, as it were, change in weight, then it might be the difference between opening 2 vials of an antibiotic if you do it on a dose by kilogram basis. It might be the difference between opening 2 vials rather than 1 vial. And as the price of that medication goes up, that obviously makes a bit of a difference to the total cost. So that's it really. In summary, we've found patients are heavier. We are tending to underestimate them if we guess it, and patients can change weight, and we recommend weighing them on the day of surgery for more accuracy. Thank you.
Right. You've used up almost exactly your 6 minutes with your presentation, but not a
Sorry,
problem
short and sweet.
at all. Yeah, do you so what's your, how's this altered your
I thought
behaviour
it was a 2-minute presentation. I thought it was 2 minutes presentation, and when you said 6 minutes, I thought, oh no, maybe I have to talk for 6 minutes.
No, sorry, we have a 6 minute slot with, but
okay.
2 minute, short presentation and some discussion, but it's not a problem at all. We're
Thank
not,
you.
nobody's
Because I was bringing it out.
This is formative, not summative. There's no penalty. So thank you for all the detail. And I'm just intrigued how this is. Locally, what do you do now? How do you weigh people, and do you always do it on the day of surgery?
Yes, we are in discussion with our preoperative assessment nurses about how to institute weighing patients on the day of surgery. We are investigating which parts of the hospital actually have beds with mechanical weight capability in for patients who are obtunded and we can't weigh them. And we are increasing awareness of the cost for not having accurate weight. We're trying to work out a cost estimation of how much we may be losing to increase awareness from that point of view. But none of the patients minded being reweighed on the day of surgery. I actually did the reweighing myself, and there was no issue with it.
Right.
Oh, and on our EPIC charts, what we can do is we can have that automatically updated, so it's easier.
Excellent. Thank you very much. So I'm going to move on to the next one. It's aiming for 1 to 2 minutes presentation, so we have a chance for some chat, but not a problem if it's slightly different. So Dr. Caulfield?
Yeah, that's me, Kim here. Hi.
Hi, Kim. Let me know when you're ready to go, and I'll press go on the timer.
Yeah, so I'm happy to start now, yeah.
Thank you.
So I'm working currently in UCLH, one of the perioperative medicine fellows, but with an interest in obstetric anesthesia. So in the midst of the COVID pandemic, I've been involved with the group in establishing this COVID OBS database, or OBS COVID database. It's a cohort study, an international registry for maternal staff logged encounters with suspected or confirmed SARS-CoV. So basically, I suppose we understand that NHS data shows that healthcare workers are obviously increased risk of contracting COVID compared to the general population. And they suspect that 16.2% at the most updated data are positive are healthcare workers. So the aim of this study was to understand the current impact of undertaking clinical procedures in COVID positive patients within the obstetric community. And secondary aims was to understand if certain staff groups were more at risk, such as, and especially if ethnic backgrounds made an impact on this. The database is supported by the Royal College of Obstetricians, the Royal College of Anaesthetists, the Royal College of Midwives, the OAA, and the Chief Midwifery Office of England. So far, we have greater than 1,000 people logged into our database with over 400 counters submitted, and this is distributed across 15 different countries around the world. There's been encounters with confirmed COVID cases in 48.5% and suspected in 51.5%. Interestingly though, our data is quite low in terms of who has turned out positive. At 1.67% of any participants in our data so far have turned out positive themselves post suspected exposure at work. All participants who tested positive were midwives and obstetricians, not so much the anaesthetists or pager staff were involved. And interestingly, those who were positive were of white Caucasian background rather than any other ethnicity. I suppose that maybe reflects if you look at the chart here, that more of the white ethnicity background were actually represented in our cohort study. So I suppose in conclusion, until the introduction of OBS COVID registry, the current impact of understanding clinical procedures in COVID positive maternity patients remains quite understood. The database is there to address and to serve this issue, but I feel our encounters to date need to be improved, which is what I'm working on between the first surge and the second. Hopefully we don't get a second surge, but in the likely event that we do, that this database is set up that we can continue to track the instance of COVID occurring in healthcare workers who are exposed to positive patients. So this database continues to expand internationally and nationally.
Brilliant, thank you. So I'm going to start with the questions, if that's okay. Can this only track patient to healthcare worker infection? And the reason I ask is because it's becoming clearer that most transmission within hospitals is healthcare worker to healthcare worker or patient to patient. And it may be that there's less going on between the two groups.
So I suppose it's like a logbook, like you'd have for an anaesthetic logbook, like an encounter for a patient that you'd anaesthetize. So it's a similar kind of setup. So the participant can only really log an encounter with a COVID patient. I suppose they could log it with the staff as well if they wanted, but that the setup is not there currently.
Yeah. There's a reasonable case that we're more of a risk to each other than our patients are to us, or
yeah, exactly. No, I totally agree, and I think that's how previous pandemics kind of prolonged within that's how I think previous pandemics maybe resurged or lasted longer because of healthcare workers. Yeah.
Any questions from others on the call? Okay, I'm going to ask another one. So, how do you get a feel for the denominator for all of this? How representative what you're tracking is likely to be of overall practice?
I think, well, in terms of staff exposures, I suppose why the obstetricians and midwives are more at risk is they probably, I suppose, anaesthetists are going to wear more PPE, like the greater instance of exposure for the anaesthetist in terms of procedures that they're doing would be related to anaesthetic. So invariably, while this was being done, we probably were wearing a lot more PPE, whereas the risk, I think, profile on the ward or where you're not suspecting a patient, where you're maybe not as vigilant in terms of PPE, increases your risk. And I think that's potentially why our midwives and obstetricians are probably more exposed. And that's probably an interesting thought going forward, that, like, I suppose it's reinforcing the fact that we should all be wearing masks in the hospital. And I think that practice has probably changed since this data was collected. So it will be interesting to compare if things get worse again in terms of second surge, how this data adapts as people log more cases.
Yeah, and if I read it right, so 1.67% tested positive, of whom all were white Caucasian.
Yeah.
And do you have any thoughts? I mean, do we think that the BAME clinicians are being more cautious or better in their behaviour with PPE because of a feeling of excess risk, or do you have any sort of explanation for that?
I have no explanation for that, but I'd hope that that's the reason, and maybe there's because of increased awareness of their increased risk that they are taking more precaution. But I've no definitive data to explain that.
And do you know what it looks like by gender? Because obviously one of the biggest risk factors is just being male.
Yeah. Well, I think I do, but I didn't actually look that data up. I could readjust my data to find that out. But I think in an obstetric hospital, the predominant is for female versus male, but I didn't actually look at that, but I can for sure.
Cool.
Yeah.
Great. Okay, well, thank you very much indeed.
Okay, no problem, thank you.
Great presentation. Okay, so our next presentation is Dr. Riley.
Hello.
Hi there, hi Catherine.
Hello.
Let me know when you're ready to go and I'll start the clock.
Yes, yeah, I'm ready to go.
Thank you.
So my poster was about reducing pediatric perioperative exposure to environmental tobacco smoke. By this, we mean exposure to the products of burnt tobacco, which can be from the tip of burning tobacco products, a burning cigarette, from exhaled smoke, or from third-hand smoke, which is smoke that's adherent in the environment to clothes or hair or upholstery, for example. And I've put there a little box of the risks that a child comes to from being exposed to environmental tobacco smoke, which most of them are no surprise. There's a general risk to the child's health of lower respiratory tract infection, sudden infant death syndrome, bacterial meningitis, to name but a few. There's the risks to the rest of the family as well. Obviously, the smoker is at risk. And if a child lives with a smoker, then they're up to 90% more likely to become smokers themselves, with all the attendant health risks that brings. But also, a child who's exposed to environmental tobacco smoke has increased risks from their general anaesthetic. So they're more likely to have an adverse respiratory outcome, which includes laryngospasm. In fact, they're 3 times more likely to have an episode of laryngospasm, but also they're twice as likely to have other respiratory adverse events like hypoxia and bronchospasm. They're also more likely to spend a longer time in the post-anaesthetic care unit. They're more likely to have an unplanned overnight admission as well. And there's risk from the surgery as well, about delayed wound healing and infection, for example. So we know that this perioperative period presents a teachable moment that can motivate behavioural change. And there's good evidence to show that parents who smoke are twice as likely to have a quit attempt in the weeks following their child's surgery. So this is a really good time for us to get involved with this public health message. And actually that ties in with the NHS's long-term plan and their campaign called Making Every Contact Count, which aims to embed a public health message into every contact that a healthcare practitioner has with a patient or their family. So when we were designing the perioperative care service in Sheffield Children's Hospital, we wondered what best practice might look like and what other centres are doing. So we did a national survey and got a reasonable response from 34 units throughout the UK, with a good mix of secondary and tertiary paediatric centres. And of those 34, only 6 say that they routinely screen for exposure to environmental tobacco smoke. And of those 6, only 2 had access to smoking cessation services locally. One of the free text responses says that funding had recently been lost, so they could only refer back to the general practitioner as their only option. But this just seemed like a good opportunity to target this public health measure. It benefits the child, during the perioperative period and potentially for the rest of their life, including the rest of their family. It seems like an incredible opportunity to make the most of. And it's done, interestingly, from the poster that we heard just before the last one about measuring weights. We do weights routinely, don't we? And we screen much more easily, therefore, for childhood obesity and can make those interventions. So we should be doing the same for smoking. I've put a little list there as to some of the challenges, perhaps. And knowledge about this is probably one of the biggest things. So in Sheffield, we've made some posters, some aimed at families and children who smoke, and some aimed at staff to remind us of the risks of the exposure to environmental tobacco smoke and the benefits of stopping and how that might be achieved. Time is thought of potentially as an issue, particularly in pre-op clinic, where time is always a premium. But actually one of the interventions that we have been teaching is this very brief advice, which they say only takes 30 seconds. And there's good evidence to show that in its asthma outpatient clinics, actually it doesn't increase the time of the overall clinic or of that patient encounter. There are some challenges of the parents who smoke might not be, well, they won't be our patients in paediatric setting, so they won't be registered at our institution. They might not even be present in the consultation altogether. And if they've come from out of area in tertiary paediatric care, then they might not be eligible for referral to local smoking cessation services, which could be a challenge as well. So the last bit about the solutions that we've tried to put in place is that we're now screening by asking in the health screening questionnaire and also measuring exhaled carbon monoxide in children who are willing to do the test to see to try and screen for exposure to environmental tobacco smoke, and then do this this intervention to try and help.
Great, thank you. The carbon monoxide I'm interested by, because one of my questions was going to be, is there a reliable test? Because I would imagine, and I don't know, but that would have quite a lot of traction with a parent if you could test the child and say, oh, are you a smoker? Because we appear to be able to find evidence of tobacco smoke in your child.
Exactly, yeah. Objective evidence, it does seem to be one of the most compelling things, doesn't it, to say, because I think it's easy to explain, oh, I smoke in the garden, so it doesn't count. But if you can show that it does matter and the child is absorbing that exhaled smoke, then it would be quite compelling evidence, wouldn't it? What we can do is we can measure cotinine, which is a metabolite of nicotine, which is present in the saliva, the urine, and the plasma. But there's no reliable sort of bedside test or point of care test for that. And the thought of getting urine or plasma off every child who comes through pre-op just seems insurmountable, really.
But a rapid diagnostic for cotinine, so a saliva rapid diagnostic might be very handy.
Yes, it might. I don't think that's available commercially yet, certainly for clinical practice. Exhaled carbon monoxide, though, there's good evidence to show that the amount of exhaled carbon monoxide correlates very well with the amount of environmental tobacco smoke that an adolescent is exposed to. But that evidence is lacking for younger children, probably because they have to do a vital capacity manoeuvre to get an adequate end tidal sample, and that might be difficult for smaller children. But in the absence of that evidence, we thought it's probably a reasonable enough thing to start with, at least. The risk, though, is that a child won't do it properly and will blow negative, and therefore it sort of negates the whole thing. The parent might easily think, oh, well, it obviously doesn't matter then. So that's the risk that we're taking doing that, I think.
Great, thank you very much. Very interesting.
Thank you.
Okay, we're going to move on to the next one. Dr. Aswath, Avinash.
Yeah.
Okay, let me know when you're ready to go.
Yeah, I'm good to go, yeah.
Excellent.
Yeah, I'm Avinash. I currently work in Dorset County Hospital, and I'm doing the advanced training in perioperative medicine. I also did advanced training in regional anesthetic in my previous hospital, and this audit was in Bournemouth Hospital. So basically, the study evaluates the efficacy of continuous popliteal block for major ankle surgery. So we looked at efficacy and the safety aspects. And this was done following an audit previously done in the hospital, which showed the continuous popliteal catheter block are better than the single shot in achieving good pain relief for a few days, like first post-op and the second post-op day. And so we thought we'd test this one and see what were the complications following that audit. So we looked at data from 2016 to 2019. It was all single operator major ankle surgeries, and we looked at catheter, whether the catheter stayed in for the total 54-hour duration, and whether the pain relief was adequate, and whether there was any problems related to catheter, any major complications like local anesthetic process. So the audit was done retrospective collection of data from electronic records. So nowadays we got everything on Evolve or electronic, so it's easy to trace them. So we looked at anesthetic charts and pain team review charts, look at the pain scores, numerical pain scores. And we also mentioned any catheter-related problems like leakage and whether that's no block or patchy block. So the popliteal block basically blocks a major aspect of ankle, but there is a certain area which is obviously saphenous nerve cover segment. So patients would be having other pain relief as the additive. So we looked at the total opiate consumption, and we took analgesic dose by comparing if they've had codeine, so the equivalent of morphine. So we added everything to as equivalent dose of morphine. So the patient demographic data, majority of them were ASA2 and a few ASA3 patients. 50% had total ankle replacement, and majority of other 50% had fusion, ankle fusion, and there were a few other major surgeries which didn't fit into these two criteria, but the major ones. Tourniquet time was also looked at, and some of the surgeries they had to reapply the tourniquet, so we just took the total time. The average was 155 minutes. And the anesthetic was standardized, so we looked at only the cases who had a block and a general anesthetic. We excluded those who had a spinal anesthetic. And the standard technique of insertion of catheter and fixing also was standardized, so we made sure that only those cases were looked at. A total of 63 were selected, and 3 of them were excluded because of reasons like we couldn't get the patient records in the Evolve or on the electronic records, or some of them were like had a graft taken, so another area, so it cannot be exactly covered by the population. So we looked at the efficacy, so average pain score. In the first 3 days, it was like 16 milligram in total and 38 milligram for the second day, 44 milligram for the third day. And the catheter will last only for 54 hours, like 2 days plus half day. And the safety, we looked at the catheter site leakage or any block problems like no block or patchy block, and also like any infection signs or redness. And major complications like local anesthetic toxicity during the stay in the hospital while they had the catheter infusion. These are the results. So basically, the pain scores were less than 5 first 3 days, and they did have other opiates, and the total was like 16 milligram the first day, 38 and 44 on average on the second and third day. After that, it steadily increased, and they also add additional non-opiate analysis like the gabapentin and other things. So they were being reviewed by pain team and prescribed other medications. And we also looked at the catheter leakage according to the days that they had. So around 15% had catheter site leakage, but otherwise it worked well for the first 2 days definitely. And I think there was, during the study period, there was no major local anesthetic toxicity in any of them. And we thought the study would probably show us or put some confidence in us that we can plan further in sending the patients home, at least a selective few of the patients home with the catheter, with clear instructions on how to manage them, and have a follow-up arranged by telephonic follow-up on the day, next following day until the catheter is out. And then so we could reduce the length of stay and also have good pain relief for patients.
Thank you. I've got a couple of questions. One is, did any of your patients avoid opioids altogether?
No, in this study, I don't think anybody had avoided, but there were a few who already had opiates, like they were on chronic pain medications.
Right.
But yeah, I think, yeah, majority are okay.
So everybody would have had a little bit of opioid dose as well as the block?
Yeah, because the saphenous nerve
And
was not like having a continuous catheter. It had a single shot. You did a single shot for saphenous nerve, that's adductor canal block. So the saphenous area for like, especially for total ankle replacement and the fusion, that part was not covered. And we don't know whether it was just that part or whether it was just like an opiate supplement inside.
Great, thank you very much indeed.
Thanks.
Okay, our next presentation is Dr. Hogan.
Hello, can you hear me? We've had some difficulty.
I can hear you very clearly. I can't see you, but that's fine.
No.
We can hear you
We've
very
had
clearly.
to sacrifice image for auditory. Thank you again, back from Madam Brooks. I'm going to talk about our audit, which looked at orthostatic hypertension and intolerance, which we measured preoperatively and its association with postoperative outcome. Again, there is a number of co-authors who had helped with this study. So the issue is that dysautonomia, orthostatic intolerance and orthostatic hypertension, that spectrum is poorly understood in many respects in terms of surgical outcome. There have been a few studies, 3 from Henrik Hellick's lab, but they tend to have small sample sizes, and I think one in the BJA had 16 patients only. So we wanted to look at it in a much more simplistic way. We defined OH, orthostatic hypertension, traditionally according to standard criteria, and recorded it at preoperative assessment clinic, which was ideal because we included patients who had a 12-lead ECG, so we were able to get that 5-minute supine period before measuring supine blood pressure. We went through our EPIC electronic records and looked at post-operative events, including the length of stay and any physio, nurse or doctor record or any healthcare professional record of a patient falling, feeling unsteady or experiencing dizziness, otherwise defined as orthostatic intolerance. We had approximately 170 people for baseline assessments. COVID then intervened, so the post-operative data is based on a sample of 142, but not bad. So as you can see, we had a rate of approximately a quarter of our patients, if you see the middle figure with the black bar at the beginning, had one drop at either 1 minute or 3 minutes in either systolic or diastolic blood pressure. So a quarter of the population had met the criteria in one way. Systolic blood pressure was more affected than diastolic, as you can see. And in patients where we achieved both a 1 and 3 minute standing measure, then we showed that approximately half the sample had a BP drop at both 1 and 3 minutes. I just want to clarify that the proportion of patients who didn't manage a 3-minute measure, that wasn't because of symptoms with them, it's because we have an exceptionally busy preoperative assessment clinic and it was nursing capability. So in terms of relation to outcome, the length of stay was a median of 2 days in those with orthostatic hypertension and 1 day in those without, and that was significant. And then any event of falls and steadiness or dizziness was found in 1/3 of the population with orthostatic hypertension, whereas only about 7% of the population in those without. And I would say that the post-operative note review was carried out by myself, blinded to the postural hypertension data. So we also controlled for a whole host of other things, including all of the intraoperative blood pressure recordings, which are measured automatically, blood results, hemoglobins, creatinins, lots of other things with drugs as well. And there were no significant difference between groups for that. So perhaps with a larger sample size, we have managed to find an effect which nonetheless should be replicated in further studies, and showed that a quarter of our patients who are ASA 2 and above have orthostatic hypertension and have greater problems with their post-operative morbidity after. Thank you.
Thank you very much. How much of this do you think is, so you talked about autonomic dysautonomia at the beginning.
Yeah.
How about simple fluid status, in terms of how much fluid they had during the surgery, how quickly they drank afterwards, and how dehydrated they were beforehand?
Well, I think actually the best data to inform this, I mean, I know about the fluid studies in anaesthesia, but the best data to inform it is the data with the POTS, so the postural orthostatic tachycardia syndrome in the cardiology literature, because they talk about means of protecting these patients from intolerance. They have showed, you know, to get them onto oral fluids is probably the best thing as quickly as possible, and that patients who are underfilled, you would expect perhaps have a greater degree of orthostatic hypertension, but it's not as clear cut as that, because we've also got to take into account the sodium, which the POTS literature also talks to, and reinstating antihypertensives very, very early post-operatively, whereas some patients, they weren't reinstated early. So there is a lot of work to do in looking at that. I think fluid is a part of it, but it's definitely not the full story.
Thank you. And any questions from others on the call? Everybody's very quiet this morning. Understandable. And just going back to the fluid story, do you routinely give people, I mean, a sort of enhanced recovery approach with drinks in recovery, or is there a delay? What is the Cambridge approach?
Well, Cambridge approach is very much down to individual anaesthetists, and I should be careful because I've got a few consultant anaesthetists sat behind me at the moment, but it's down to the individual and the type of surgery. But yes, there is a link it's more than we don't have.
Sorry, we lost you a little bit there, Alex.
We have a patient.
Okay,
Connection overhearing.
Yeah, apologies, your signal's breaking up a little bit, but thank you very much for that.
Hello?
Can you hear me? Thank you very much, Alex. Apologies, your signal is breaking up a little bit.
I think I'm back now, but
okay. I apologise. I'm going to move on, but thank you for that. Great presentation. Dr. Breckenridge.
Hi there. I'll just get started.
Okay, good to go.
So I'm Fiona Breckenridge. I'm an anaesthetic registrar in Glasgow with an interest in perioperative medicine. We know of the benefits of prehabilitation for perioperative risk, but we weren't currently giving any active support to patients with this in our hospital, and we wanted to improve this for our patients. We thought it was important to first gauge patient knowledge, motivation, and what format of intervention our patients would be interested in, as these are all key for successful behaviour change. All patients at our pre-op clinic were surveyed over a 2-week period in March of this year with interesting results. So the bar chart at the bottom left shows patient knowledge and highlights that a significant percentage of our patients lacked knowledge on the benefits of prehabilitation. For example, 43% of our patients were not aware of the benefits of increasing activity levels. So we felt that there's a real need to improve baseline knowledge for patients here. The table in the middle of the screen highlights that in general our cohort of patients are motivated to make behaviour changes at this time and to improve their lifestyle risk factors. Figure 3 on the far right of the slide highlights patient perception of weight. That's in the orange bars compared to their actual BMI, which is represented by the blue part, the blue bars in the chart. And that shows that patients are on the whole perceiving themselves to be of a lower BMI category than they actually are. Only 13% of patients in the obese category or morbidly obese category recognised that they were actually obese. So again, I think this highlights that we need to improve understanding for our patients before we can expect to see behaviour change. Lastly, just to highlight the bar chart down at the bottom in the middle of the screen showed that 57% of our patients were interested in support, and it highlighted what type of support patients were looking for. So along the bottom, type of support, and it's broken down by age range of the respondents as well. Most patients were looking for written information as to how they could improve lifestyle factors, and that was followed by a request for advice from healthcare staff, and then following on from that, app or web-based support. So on the back of this, we've responded by giving all patients the Fitter, Better, Sooner leaflet from the Royal College of Anaesthetists, and our nursing staff at preoperative assessment are providing a very brief intervention, giving lifestyle advice to patients and signposting to additional support. And that's something that we hope to develop going forward. We've still got further work to improve prehabilitation for our patients, but I think this has been a good start to look at that process. Thank you. I'm sorry, I'm not able to hear you, Mike.
Sorry, I'm a loop muted to be polite, and then was amateur and didn't switch it off again. Do you have any feel for how this compares to other regions? So, you know, what has other work been done in this area?
So, not that I'm aware of in our region. So I'm sure that other work looking at this has been done across the country, and I'm not sure about that actually. Although it would be interesting to see certainly some areas of Glasgow have a relatively deprived population, and incidence of kind of poor diet, low exercise levels, and obesity is quite high in our patient population in general.
And do you have good services to signpost people to? So if you wanted to point them in the right direction, is there something to point them at?
So not easily accessible, but actually when you go looking, there are a number of NHS-backed apps or websites, and there are actually local resources as well. So, for example, when I've gone looking, there's a Live Active service within NHS Greater Glasgow and Clyde, and that takes referrals for patients looking to increase their activity levels and can provide telephone support for patients to be able to do that. So I think there are health promotion resources available, but it's a case of finding what's available in our location and making sure that we can signpost patients. And I think that's where we've got more work to do, to make sure that we're tying in services that already exist, and making sure patients can access them.
Yeah. Any questions from other people on the call?
I've got, it's more of a comment if I can, than a question, but I'm just wondering about sort of patients' motivations. If their perception of their weight is, by and large, they are a normal weight as opposed to overweight and so on, just trying to get them to engage, I'm assuming, is going to be that much harder. And in a way, it contrasts with the first presentation, where patients seem to be more accurate at judging their own weight, or at least quantifying it. And it just seems like a barrier.
I guess there's a difference. They may know their weight, but they may not contextualize it as being obese, I guess. Do you have an impression from the people you were dealing with in Glasgow in that respect?
I think that's probably quite accurate, that actually knowing where you sit in BMI is a further from knowing what your weight is. And I think you're absolutely right, it is a barrier, and it's something that we need to address, and we have an opportunity to do that in pre-op assessment when we're measuring weight and recording BMI, and that's a missed opportunity if we're not using that to address patient education at that time, I think.
Great, thank you very much indeed.
Thank you.
Next up is LJ. So let me know when you're ready and I will start the clock.
Yeah, I'm happy to start. Thank you.
Thank you.
So one of the key standards coming from the National Emergency Laparotomy Audit, NELA, is that patients with a predicted risk of mortality of greater than or equal to 5% should be admitted to critical care. And actually that now forms part of a best practice tariff. So trusts also get paid if they meet that standard in 80% of patients or more. So we sought to look at a cohort of patients who were admitted to critical care post emergency laparotomy to understand the types of care that they actually received, and look at how their outcomes, their mortality outcomes, might differ by the type of treatment that they received. And also sought to understand whether there was a subset of these patients who might actually be suitable for care within an enhanced care unit as opposed to requiring full intensive care. So where sort of support and monitoring and so on is offered at a level between that available in the surgical ward and a full critical care unit. So we took about 4 years worth of NELA data, linked it with the intensive care audit, the ICNARC case mix program data, managed to link about 40% of patient records, leaving us with about nearly 25,000 patient records. And really the key finding is within the table that about a third received only basic levels of cardiovascular support, meaning either invasive arterial pressure monitoring or central venous pressure monitoring, or a single vasoactive agent as an infusion. And that's the sort of care that we envisage could be offered within a level 1.5 or enhanced care type of setting. And actually one of the really fascinating things is that we found that their observed mortality was actually about half of their predicted mortality. This is prediction with the NELA risk prediction model. And they also required the sort of support, these levels of basic support, for a relatively short time, a median time of about 2 days. So it's quite a large, the takeaway of this is that, first of all, it's quite a large proportion of those patients that we admit to critical care. And secondly, they do receive support that might be offered away from the full critical care unit, which is presumably somewhat topical at the moment with pressures. And also, they actually do better than we might otherwise anticipate. That's it.
Thank you, LJ. So about a third of patients don't need the level that's available to them. But if they're, I'm sort of turning your results around slightly, which may be slightly unfair, but if their outcomes were less than their predicted risk was higher than it should have been, how can you identify them up front? Because it sounds like they appear to be high risk, so you'd be nervous of putting them in such an environment, and yet they look like they might benefit from it. So how are you going to discriminate between those who need it and those who don't?
Sure. I mean, that's definitely a barrier, and it would end up coming down, I think, to a degree of clinical judgment, seeing how things were after the operation, but also according to local setups. And I think each hospital in this case would be needing to determine that for themselves. But yeah, it's a very fair point, and it's actually potentially quite difficult, especially as increasingly I think we move towards assessing risk by sort of more objective means like these models. The NELA model itself performs generally very, very well, but it is also being updated with a sort of more recent patient cohort in mind. So that might also have an impact upon things.
And I guess it appears that we're going to have a lot of new ICU capacity post-COVID. It may be that you worry less about where you put them, but it's how you care for them in the environment that they are. So if they're doing well, you can nurse them on a 1 to 3, 1 to 4 basis, but if they start to wobble, you change that, I guess.
Yeah. And that is kind of the idea behind the level 1.5, the enhanced care units as well, that you have immediate access to critical care in addition.
Yeah. Any other question? Any questions from the others on the call? Where are you going next with this, LJ? What's the next piece of work that follows this?
So for this is more or less as is. I'll be talking about it in far more detail with the NELA team, because it will influence sort of policies going forwards, particularly surrounding the best practice tariffs and so on.
But could you trial this?
Yeah, I hadn't thought of doing that, but yes, I think you could. I mean, a lot of units do have enhanced care sort of as part of the full intensive care package, where they are responsible for looking after those units. So actually, yes, I think you probably could.
It feels, I know people get very vexed about the notion of inverted commas, no care, so ward care versus intensive care. But if you're trialing 2 levels of augmented care, there might be more comfort with that, particularly if you had a good safety net.
That's true.
Thank you very much indeed. Next up is Dr. Hogan. You there?
Hello. I'm hoping it's working again.
Good luck.
Professor Grocott, may I just take the opportunity to apologise to my fellow trainees in the room. Although we haven't been able to hear everything you've been saying, we have seen your posters, so I do apologise for the in and out from Cambridge here.
Yeah, I think you're doing remarkably well under conditions of adversity.
Thank you. So the final poster for this session, I'm going to talk about our own experience in change and theatre efficiency and practice during the pandemic. And of course, I'm talking about the peak. And in the abstract, I talked about the peak. I have now added late COVID, which constitutes May. So just a heads up with that. But we have a large department with 164 anaesthetics staff and a large number of theatres. And as every hospital, we were required to very quickly incorporate personal protective equipment, aerosol generating procedures and new protocols, airway guidelines, etc. We wanted to do a continuous running audit of how it was affecting our practice so that we could feed back to staff and use it to plan reopening theatres as and when. So we had audit office approval to go back and look at patients' epic chart review. And to just say, we determined that we needed a historical group. So what I actually did was the group who I've just spoken to you about, the postural hypertension group, we repurposed that group and went back and collected some more data from them to act as a baseline, because that was between August and February. So the approach we took was a couple of ways. We looked at a point prevalence identification of cases, which is what I'm presenting to you at the moment, but we also did a surgery specific, which I will hope to present at a later date. So in terms of the efficiency, first of all, case times, as you can imagine, across all surgeries, but not including neurology, neurosurgery, cardiothoracics, or our obstetric theatres, case times increased compared to historical values, particularly in the peak time, and have only slightly come down during May for the late COVID period. And of course, that's going to be significant, as you can see there. But of perhaps greater interest at the moment is what's happening with our airway stuff. So we have noticed that consultants are doing more of our airways because our trainees were redeployed mostly. And also our senior clinical fellows continued to work at the, do airways at to the same degree, but the consultants increased and the trainees decreased. Our ETT use and laryngoscopy increased with, of course, the supraglottic airway use coming down drastically, and use of auscultation to confirm airway placement was also drastically decreased from approximately 40% use down to less than 10%. And also bagging was decreased. One of the considerations with not using auscultation as much, one of our critical care consultants was concerned that we might have inadvertent endobronchial intubation rates would increase. Now that's the reason I have included the endotracheal depth, which was automatically recorded on the chart. So the theory being that if we had more endobronchial intubation, we would likely see an increase in the mean depth that our tubes were put in at. So using that proxy measure, that didn't appear to be the case. We also, you can see here a graph, the laryngoscopy attempts. Most of our cases continued to be first pass, and all the oxyhemoglobin saturations throughout our automatically recorded anaesthetic charts showed that there was no increase in the rate of O2 desaturation. So we have fed back to our theatre, to our anaesthetists as a whole, that yes, there is decreased efficiency. They're not just imagining it. That the airway practice has changed quite dramatically. However, the adaptation of taking longer to do something perhaps has meant that we've prevented any detriment to patient safety in terms of airway. And from this point of view, I compare it to my high altitude work, where people at high altitude slow down, but actually becoming slower facilitates you being surer in those kinds of circumstances. So thank you very much.
Thank you very much.
Thank you.
So I'll resist the temptation to interpret your graph, your right-hand graph, that when your consultants do more airway instrumentation, there's less first-time successes. I'm sure that's, that was entirely
no. There's more consultants doing it, but no, don't interpret it the other way around.
No, I understand. So just a question about the other graph.
Yeah.
If I'm reading it correctly, the proportion of ASA3 cases went up substantially to from about a quarter to about a half.
Yes, I'm sorry, I've lost this I've lost the screenshot of the actual thing that you're looking at, but yes, let me, I've got it on paper here, hang on a second.
I guess the question is whether your increase in length of case is related to the COVID-related factors, or actually it's simply that you would selecting the higher risk cases and they always take longer anyway.
Yes, so I've spoken to this in the abstract in a little bit more detail. Of course, the baseline group were identified at preoperative assessment, and they had a lower ASA, but they had an older age, so they're approximately in their 70s, whereas the COVID groups were made up of capture from the theatre lists on a daily basis, and particularly during peak COVID, that would have been your emergency appendix and everything, which is going to be the younger cases. So the baseline group were older, but had lower ASA grades, and the opposite happened in our COVID times. But what I'm actually using, I'm using a reliable change index to look at that in more detail now.
Great. Thank you very much.
Thank you.
I could hear all of that one all the way through. Thank you. Okay. We're going to move to the next, and this is the final presentation, which is from the South Yorkshire Audit Research Collaboration.
Can you hear me?
I can.
Yeah, okay. So my name is Mark Prince. I'm one of the registrars in Sheffield. So I'm going to talk to you about the perioperative management of obstructive sleep apnea. So this was a region-wide practice survey that the South Yorkshire Audit and Research Collaboration for SHARC facilitated. So really we were looking at this because sleep apnea is increasingly common and it's associated with perioperative adverse outcomes. And it also leads to sort of there's a sort of dilemmas in how you manage it afterwards in terms of where the patients go and how you look after them. So we surveyed all of the hospitals in the Yorkshire and Humber region, which was 14. We got 11 responses with a 79% response rate. These are the main things that we found. So we found that there was 45% of cases they routinely screen for OSA using a validated tool, so like StopBang. 82% of the time, never measure a venous bicarb for any reason to help them sort of categorize people into various different risk groups. 36% of the time, care was escalated following a diagnosis of OSA, which is obviously not very much. And 50% of the time, elective cases were cancelled on a weekly or monthly basis due to a lack of dedicated post-op facilities for OSA patients. So we then looked at the patients who already had OSA that were coming through pre-op assessment, and those that had their own CPAP machine. And if they did, then 82% of them just went to a ward and were managed that way. But if they didn't, 73% went to critical care, which is obviously a large number of patients to go to critical care for something that could be managed elsewhere if they had the right facilities and equipment. So what we really found with this was that region-wide, there was a huge variation in clinical practice between different hospitals treating the same patients with the same things. And the implications are that there's potentially avoidable critical care admissions, which are costly and also potentially stop other patients going there who may need the facilities more, and very frequent cancellations, often on the day, which is bad for patients and for us as well. And that's a summary of it, really. If you've got any questions, then fire away.
Thank you very much. So I wonder how, in terms of other things we think of in the preoperative pathway, how rapidly for you locally could you get OSA seen in a clinic and CPAP prescribed? As in, is there if you could identify this early preoperatively, could you actually convert some of your critical care group to a level 1 surgical ward group? So
there are things you can do. So I don't think there is an easy way that you could get CPAP prescribed for somebody who wasn't on it at home in a non-critical care setting at the moment. What there is, though, that's frustrating is that when you actually look around the region, there are other ways of managing it, which some hospitals have set up and others haven't. So, for example, one of the hospitals has managed to organise a dedicated kind of a ward or part of a ward where patients have monitoring overnight, which is essentially just pulse oximetry. I don't think it's very much more than that. And they have the right number of staff who can keep an eye on it. And then some of the patients will just go there and be monitored. Whereas there are other hospitals that for that same group of patients that are, they don't necessarily need their CPAP, but they need to be monitored, they have to go to critical care. So I think there's definitely scope to change the pathways for things like that. In terms of prescribing CPAP, and I think that's probably more, that would need a bit more involvement. But there's definitely a lot more that can be done.
Understood. I guess what I'm wondering is whether your 73% are going to critical care, whether like many other things perioperatively, they represent a previously undiagnosed population that would be helped almost from a population health perspective in being instituted on appropriate care, or whether actually they wouldn't meet criteria for that. I'd just be interested to know.
I think you're right in that often pre-op is the place where these things get diagnosed, don't they? And probably there is a subgroup who would probably benefit from CPAP longer term. I suppose the difficulty is there are lots of other things that come through pre-op that fall into that same category, isn't there? And we have these kind of debates about, well, you see a patient and should we start them on these antihypertensives and should we do these other things? And they'll, these things have been picked up in pre-op, and should we just send them back to the GP, or should we do something about it? You're probably right, there are going to be those patients, but particularly I think for the urgent cases, like the cancer cases, there's just never, it's going to be very difficult to get the time to be able to put those things in place before the operation. It's something maybe somebody could think about, but the practicalities of it would be difficult at the moment. Most of those patients that are going to HDU, that's 73%, a lot of them are not actually having CPAP. They're just there because that's the only safe place to send them.
Sure. Great. Thank you very much indeed. That is the final presentation, I'm afraid. I know you're all enjoying yourselves, but we must move on. Three comments before we go. First of all, thank you very much indeed for taking the time to prepare your posters and do the presentations today and contribute questions and discussion. The second thing is that this was, I hope, recorded. I believe it was recorded. But if you don't want your presentation accessible online, please let us know. So our impression was that most people would be keen to do that, and we're going to edit these down so each presentation can be accessed in the abstract room during the conference for people who choose to go and look. And then the final thing is, if any feedback on the process would be gratefully accepted in terms of this bit or the screening of the abstracts. We're very much learning by doing in the virtual environment, and any feedback would be wonderful. And if you choose not to do it now in front of lots of people, feel free to email us afterwards.
I think it's worked really well.
Yeah, thank you very much.
Thank you.
I think it worked. We all thought it worked quite well here as well. The bits that we could hear were really, really clear, and yeah. And actually, we've got you all on a widescreen as well, so we've been able to present. But then I'm looking up because we've got on a widescreen, so more people in the department have been able to watch, and we've all enjoyed it. Thank you.
Brilliant. Well, thank you all very much, and we look forward to hopefully you joining us next week from Saturday onwards. Thanks a lot.
Thanks.
Thank you.
Where are we? Stop sharing.